The title of my talk today are Dementias Associated with Parkinsonism, Diagnosis and Management. And I want to start by identifying our sponsors and thanking them. And then I also want to let you know that I have no financial relationships with commercial interests within the last 12 months, and I have no further disclosures. So the topics that I'm going to be discussing today are all related to dementias associated with Parkinsonism. And I'd like to start by defining what I mean by dementia associated with Parkinsonism, and I'll review the frequency of the conditions. I'll discuss the diagnosis of the different causes of dementia with Parkinsonism, and I'll compare the clinical and pathologic features of these dementias and discuss the management of these conditions, including cognitive and behavioral symptoms. When I say cognitive, I mean the thinking, memory, concentration, all the thought processes that are impaired in individuals with a dementia syndrome. And behavioral issues, of course, are related to abnormal behaviors that an individual might have with dementia. And then I'll discuss the effects of these conditions on caregivers a little bit at the end. So I'm really going to be focusing today on two of the most common disorders associated with dementia and Parkinsonism, and that is Parkinson's disease with dementia. And by Parkinson's disease, I mean the movement disorder or the motor disorder that with dementia that develops later on, at least a year after the development of the motor syndrome. And then dementia with Lewy bodies, which is another condition associated with similar pathology to Parkinson's disease, but where the dementia begins prior to or at the same time as the movement disorder. And then I'm going to cover clinical features and management of a few atypical Parkinsonian disorders that are associated with dementia, but are much less common. And these include progressive supranuclear palsy, multiple system atrophy, cortical basal degeneration, and vascular Parkinsonism with dementia. And when I say vascular Parkinsonism with dementia, I don't mean the large category of vascular dementia. I mean a very small specific category of Parkinsonism with dementia that is related to multiple small strokes. So obviously, dementia with Parkinsonism requires that a person have dementia and requires that they have Parkinsonism. And when I refer to dementia, what I'm talking about is an acquired impairment in memory and at least one other cognitive domain. And those other domains include language, visual spatial ability, or the use of vision to analyze information and locate objects in space, problem solving ability, and then mood, personality, and judgment. Now, the impairment in these areas, in order to meet criteria for dementia, the impairment must be severe enough to interfere with social or occupational functioning. The second component, of course, is Parkinsonism. And Parkinsonism is characterized by really four core features. The first one is rest tremor. And by rest tremor, I mean a shaking, a rhythmic shaking, usually beginning in the hands, when the person is in quiet repose or resting. And the tremor tends to come out when they're at perfect rest, and it goes away when they start to use the limb. So that is opposed to the more common tremor that we think of called essential tremor, that is characterized by worsening of the tremor when the person tries to do something with the limb. So rest tremor is associated with Parkinson's disease. And the second characteristic is rigidity or joint stiffness. And the way that we test rigidity at the bedside is just passive range of motion of the joint. We ask the person to please relax, and then I pick up the limb and I move it throughout its entire range of motion. And what I'm feeling for is a resistance to that passive range of motion that we call rigidity. And then bradykinesia just means slow movement. And obviously, we're assessing slow movement the moment that the person walks into the clinic. We're looking at their walk, we're listening to their speech, we're looking at their facial expression, and then we ask them to do certain tasks like tap their fingers or move their hands rapidly in order to assess for this bradykinesia or slow movement. And then the final characteristic is postural instability or impairment imbalance. And this, of course, is important because it leads to frequent falls and it can lead to injuries. So any two of these characteristics will meet the criteria for Parkinsonism. So all these conditions that I'll be talking about have Parkinsonism and dementia. So what are the frequency of these Parkinsonian dementias? Well, starting with Parkinson's disease, we know that the motor disorder is present in about 1% of the United States population over the age of 65. At any given time, about 30 to 40% of these individuals have a dementia. So if you think about it, about 0.4% of people over the age of 65 have Parkinson's disease dementia. Now, dementia with Lewy bodies is actually more common than Parkinson's disease dementia. If you just look at the prevalence, and when I say prevalence, I mean the total number of cases of a condition in one point in time. So if you look at a busy dementia specialty clinic, probably about 25% of the patients that are seen in that clinic are individuals who have dementia with Lewy bodies. The prevalence really is kind of difficult to assess for a variety of reasons, including different definitions and different ways of assessing a case number, but it's estimated to be about 5% of people over the age of 65 years. Now, that's compared to Alzheimer's disease, that's about 10%, and maybe perhaps a little bit more of people over the age of 65. So Alzheimer's disease is by far still the most common dementing condition. But dementia with Lewy bodies is very common. And depending on who you read, you might run across a statistic that says dementia with Lewy bodies is the second most common cause of dementia. And that may or may not be true. I think it varies across different populations, different cultures, different countries even. But the top three are Alzheimer's disease, vascular or stroke-related dementia, and probably dementia with Lewy bodies. Now, these atypical Parkinsonian syndromes, and when I say atypical, it means that they have features of the Parkinsonism that make them unlike regular Parkinson's disease. The prevalence or the total number of cases at any given time is very, very low. These are uncommon conditions, but they're important to identify because the treatment is entirely different and the prognosis is entirely different. So the three that we think of here are multiple system atrophy, and this condition occurs in between 4 and 5 individuals per 100,000, progressive supranuclear palsy that occurs in about 6 per 100,000 individuals in the United States, and cortical basal degeneration, which occurs in about 4 to 5 per 100,000 in the United States. So if you look at all three of these degenerative Parkinsonian syndromes, the total prevalence is only about 15 individuals per 100,000 in the population. So they're very rare, but they are important in terms of treatment and prognosis. So this is the slide really, when I think about frequency, this is the slide that really resonates the most with me. This is a slide of two different studies. One is the Kuakini Honolulu Asia Aging Study, and the second is the Rush Aging Study out of Rush University in Chicago on the bottom panel here. Now, what both of these studies did is they had very active autopsy programs. And they got as many brains on individuals who had dementia and died as they possibly could. So what they did is they took everyone with a dementia syndrome and they did very thorough neuropathological evaluations. And the pathologists who evaluated these brains were not given the clinical information. All they could do was identify the clinical lesions associated with each one of these dementias. So then they looked at the frequency of the most common dementias. And I think this is very interesting. First of all, in Honolulu, Alzheimer's disease, pure Alzheimer's disease, was about 12% of those brains. Vascular dementia was more common, almost a little bit more than 20%. Pure Parkinsonian dementias was minuscule. It was less than 2%. And then other things that we couldn't identify but were associated with brain shrinkage or atrophy, about 8%. But look here, this is the prevalence or the total proportion of the brains that had multiple pathological lesions associated with dementia, and it approached 50%. So mixed dementia was the most common. Similarly, in this Rush study, pure Alzheimer's disease was a little more common, about 30%. Pure vascular disease, about 12%. But again, pure Parkinsonian dementias, relatively uncommon, but over 50% of the cases had mixed dementia. So there's two lessons here, at least. One is that when you identify one cause of a dementia in an individual, don't stop your evaluation, because they may have more that need to be addressed. And the second thing here is that when we treat these conditions, you may need to treat more than one disorder. So I think that this is a really important slide. So what do I mean by risk factors for these conditions? I mean environmental factors, clinical characteristics, and other characteristics that increase or decrease a risk for developing the condition. The most common one that I can think of is smoking as a risk factor for lung cancer. So we think of risk factors in Parkinsonian dementias as well. And of course, just like any other kind of dementia, the frequency of both of these conditions, Parkinson's disease dementia and dementia with Lewy bodies, increases with age. The average age of onset of both of these is around 70 to 75 years. Both disorders are more common in men. And as I spoke about a little bit earlier, in Parkinson's disease dementia, the dementia occurs at least 1 year and often more than 10 years after the onset of the movement disorder. Whereas in dementia with Lewy bodies, or DLB, sometimes we refer to it as, the dementia is usually the presenting feature, and it occurs prior to or at the same time as the movement disorder. The other important risk factor here for both of these conditions, and this is really connected to the pathology, is the syndrome called rapid eye movement sleep behavior disorder. And this condition may occur in individuals and precede the diagnosis of both of these conditions by years, up to 10 years. So what is rapid eye movement sleep behavior disorder, or REM sleep behavior disorder? It is a sleep disorder that occurs in the stage of sleep known as rapid eye movement sleep. And it's during this rapid eye movement sleep, or REM sleep, that we all dream. And for most of us, when we are dreaming, our body is paralyzed. The only thing that is moving are our eyes, but the rest of the body is paralyzed. However, in REM sleep behavior disorder, that normal paralysis is absent, and people tend to act out their dreams. And what makes this very dangerous at times is that these dreams tend to be violent in nature, and the person can injure themselves or they can injure their bed partner. Now, we know that REM sleep behavior disorder is present in about 40% of individuals with Parkinson's disease dementia, and up to 90% of individuals with dementia with Lewy bodies. but it can occur by itself up to years prior to the development of both of these disorders. So it is a risk factor. So now I'm going to spend a little bit of time talking about the clinical features of Parkinson's disease dementia and dementia with Lewy bodies, and kind of comparing and contrasting these and going through how we tend to make a diagnosis. I already really spoke about the cardinal features: the slow movement, the rigidity, the rest tremor, and postural instability. And all of these core features combine to cause a very typical shuffling gait, soft speech, very small handwriting, and a masked face or a decreased facial expression. So that really rounds out the movement disorder. But over the past 10, 15 years, we've really come to recognize that this is a disorder that is not limited to brain function, that it involves multiple systems. And we call these non-motor features of Parkinson's disease. And this is just a partial list of those. And I've highlighted in orange those that I'm going to be talking about a little bit today. I've already spoken about rapid eye movement, sleep behavior disorder, and of course, I'm going to be talking about dementia and psychosis in individuals with Parkinson's disease dementia. So what are the other features of Parkinson's disease dementia? Well, as I said, the movement disorder precedes dementia by at least a year. The earliest signs of the cognitive impairment are really in the area of brain function that we call executive function. So what do I mean by executive function? First of all, I mean the impaired ability to plan and initiate complex behaviors. And a very simple example is following directions. We've all had the experience of talking to somebody who has impaired executive function, and we know that you can only do one thing at a time. And because the other characteristic of impaired executive function is trouble switching between tasks or multitasking. And then the final characteristic of impaired executive function are abnormal behaviors like impulsive behaviors. And the person has a lack of ability to monitor their own behavior. And this leads to poor judgment oftentimes. And, you know, I always think of these patients when someone comes into my clinic and they tease me about my bald spot, or they make off-color jokes that really embarrass their family members that are sitting there. And of course, these individuals don't mean to do that. These are impulsive behaviors that are related to the dementia syndrome. A second characteristic is in the domain of language. Now, in Alzheimer's disease, language is impaired very early and severely, and it can be impaired in Parkinson's disease dementia as well, but it's usually only in the area of word finding problems. And we call this tip of the tongue phenomenon, where the patient seems to know the word that they want to say, but they have trouble coming up with it. Now, I know everybody who is on this call has had word finding problems. I have them all the time, but we have to take this within the context of some of these other symptoms. So don't be too concerned if you have a little difficulty coming up with a word every once in a while. And then of course, the other core feature here are the memory problems. And that is the ability to recall recently learned information. And how do I assess for memory problems? And there are so many different ways. There are very good screening tools, but for me, the most effective way that I have of assessing short-term memory in an individual is just a list of words. And I want the words to be longer than they can repeat in one trial. So at least 5 words, if not 8 or 10 words, when I'm doing a formal examination at the bedside. Now, in somebody with Alzheimer's disease, the pathology is in the mesial or the medial temporal lobes. And that is the part of the brain where we learn new information. And in the earliest stages of Alzheimer's disease, the feature is that their memory feature is that they have difficulty learning new information because of the pathology in this part of the brain. So when they try to repeat a list of words, let's say they're repeating 5 words, they remember 2, they remember maybe 3 the next time, but then a different 2. And if you do 4 trials and they never get more than 3 or 4, and then you ask them to recall those words after a fill delay of a few minutes, and they may only be able to remember 1 or 2. And then importantly, you can give them category clues or multiple choice clues, and those clues really don't help them to recall those words, because the problem is that they were never able to learn the words in the first place. Now, somebody with Parkinson's disease dementia, and all of these Parkinsonian dementias, as a matter of fact, they are actually able to learn the information, but it's the retrieval part that is impaired. So when you give them a list of words, yes, they have a flat learning curve. They only may be able to learn 2 or 3 after 3 or 4 trials. They may only be able to recall 2 or 3 at the end of a filled delay spontaneously. But when you give them clues, the clues are helpful, and it helps them to remember several more of the words. And so that's what I mean when I say forgetfulness, just the inability to recall recently learned information, to retrieve that information. The other characteristics, the behavioral characteristics are also present in Parkinson's disease dementia. Hallucinations, usually visual, occur in 45 to 65%. These hallucinations can be complex and very well formed. Rain coming down from the ceiling, little animals living under the bed, small people in the room, actually relatives that are in the room. It runs the whole range, and individuals can be amused by these, they can be fearful of these, and sometimes they can act on these. Depression occurs in about 15% of individuals with Parkinson's disease dementia, and it sometimes can be very difficult to recognize because they don't express sadness. And many of the features of depression, like poor appetite, decreased energy, forgetfulness, that's part of the Parkinsonian syndrome. So it really is incumbent on the provider to ask specifically about sadness. Apathy, we're learning, is a much more common feature even than major depression. And by apathy, I simply mean loss of interest. And this is a very prominent feature, and it occurs over half of people with Parkinson's disease dementia. They just have no ambition at all, and it's very difficult to get them to do anything. And we don't have good ways of treating that apathy right now. We have some strategies that are helpful, but we're only learning how to manage it. So dementia with Lewy bodies has very specific clinical criteria. One is that you must have dementia. We've already talked about the definition of that. And then there are 3 other core features that help to make a positive diagnosis of dementia with Lewy bodies. And these 3 features are fluctuations in cognition, recurrent visual hallucinations, and Parkinsonism. And I'm going to say a little bit about all 3 of these, but only 2 are required for a diagnosis of dementia with Lewy bodies. So what do I mean by fluctuating cognition? By this, I mean very severe fluctuations in level of consciousness and cognitive abilities that can range from near normal to severe confusion. So the family members bring the person into the clinic and they say, you know, I just can't explain it. Sometimes she's just fine. She's just like herself, and we just have a really good day. Other days, she can barely get out of bed and she's very, very confused. And we don't really have a good understanding for why these fluctuations occur. They can occur over minutes to weeks, and they're completely independent of the normal daily schedule. So this is not sundowning. This is not the characteristic where somebody gets their days and nights mixed up, and at night they're up and very agitated. This is something entirely different from that. And they can be so severe that patients actually have severely reduced level of arousal where they almost look like they go blank. And this has been mistaken for seizures oftentimes. Finally, their attention span is very short. The recurrent visual hallucinations, similar to those in people with Parkinson's disease dementia, may be very detailed and well-formed, frequently of people and animals in the home. And again, the response may be complete indifference, fear, amusement, or they may act on these hallucinations, and they may develop delusions or ideas that almost certainly are not true connected to these hallucinations. So imagining that intruders are coming into the house, or seeing people in the house that want to harm the individual. And so when they begin to act on these hallucinations, there usually has to be some kind of intervention, like when they call 911, or they go to their gun cabinet, or anything that creates a safety issue. Insight may or may not be preserved, and by that I mean sometimes the individual can say, you know, I know these are hallucinations. If I blink my eyes, turn on the lights, or leave the room, they go away, and I'm not bothered by them. And then these hallucinations are generally worse in individuals with visual impairment. So as I'm going through these clinical characteristics, what's going through y'all's mind is, what are the things that we need to do to treat them? You know, keep good visual function and keep rooms lighted. And I'll go into more detail for that in just a little bit. And then the Parkinsonism associated with dementia with Lewy bodies usually occurs later. In about 75% of cases, it occurs after the onset of the dementia. And it's usually mainly rigidity and slow movement. They very rarely have a tremor. And it tends to be less severe than individuals with Parkinson's disease dementia, and they rarely have a rest tremor. And when the movement disorder needs treatment, it oftentimes is not as responsive to the medications that we use to treat Parkinson's disease, such as levodopa, compared to the responsiveness in somebody with Parkinson's disease. So what are the characteristics of the dementia syndrome in individuals with dementia with Lewy bodies? First of all, they have a very short attention span. That is the ability to attend to an appropriate stimulus. So carrying on a conversation, they may lose track easily. It's also the ability to filter out inappropriate stimuli that may be coming from someplace else. They also have prominent executive function deficits. And again, this is impairment in planning and initiation of complex behaviors, inability to multitask, and then impulsive and disinhibited behaviors that tend to demonstrate poor judgment and lack of ability to self-monitor. They have prominent visual spatial difficulties or impaired ability to use vision to analyze where objects are in space. So this translates into a real difficulty with getting lost while walking or driving. And the way that we test this at the bedside is we have them copy drawings, and they oftentimes even have difficulty copying simple drawings like overlapping pentagons or a cube. And then, of course, they also have forgetfulness. So many of the clinical features of dementia with Lewy bodies are very much like that of Parkinson's disease dementia. So here in this slide, I really want to compare some of the clinical features of the dementia syndrome between some of these different conditions, such as Parkinson's disease dementia here, Alzheimer's disease dementia here, dementia with Lewy bodies, and frontotemporal dementia. So level of consciousness, the only one that really has disturbance is dementia with Lewy bodies, and that is fluctuating. Attention, can be impaired in people with Parkinson's disease dementia and severely impaired and fluctuating in DLB, whereas usually in the early stages, it's normal in frontotemporal dementia and Alzheimer's disease. We talked about impaired naming in Parkinson's disease dementia. Language, even comprehension, is impaired early in Alzheimer's disease and frontotemporal dementia. It's variable in individuals with dementia with Lewy bodies. We talked about the forgetfulness or the retrieval memory problems associated with Parkinson's disease dementia and dementia with Lewy bodies. Whereas with Alzheimer's disease, the memory deficits tend to be more severe early on, and they have difficulty learning new information. And then in frontotemporal dementia, memory tends to not be affected until later in the course. Visual spatial function is severely impaired in dementia with Lewy bodies, where it tends to be impaired, but to a lesser extent in the other conditions. And then, of course, we talked about executive function, planning, multitasking, certain behaviors that are impaired early and severely in Parkinson's disease dementia and DLB and frontotemporal dementia. And they may be impaired in Alzheimer's disease, but they tend not to be so impaired early on in most individuals. And then finally, the behavioral symptoms. Visual hallucinations are common in DLB and Parkinson's disease dementia. Delusions tend to be a little more common in people with Alzheimer's disease. The Parkinsonism precedes the dementia onset in Parkinson's disease dementia. It can occur at the same time as the dementia, but generally occurs after the onset of dementia in DLB. You can sometimes see a Parkinsonian syndrome in frontotemporal dementia, rarely, and very rarely in the later stages of Alzheimer's disease. But if you see it early on, you should be thinking Parkinson's disease or dementia with Lewy bodies. And then rest tremor may be present in Parkinson's disease dementia. It tends to be absent in Alzheimer's disease and frontotemporal dementia, and very rare in individuals with dementia with Lewy bodies. So how do we identify these syndromes, these conditions? Because the diagnosis continues to be clinical. We do not have a diagnostic test that 100% identifies the condition. And so we really rely for a final diagnosis on the postmortem exam. And we learn how to make better diagnoses by linking the clinical characteristics with the postmortem exam or the autopsy. So the thing that really links these two Parkinsonian dementias, dementia with Lewy bodies, Parkinson's disease dementia, is the presence of Lewy bodies. That's how DLB got its name. Lewy was a pathologist who first recognized these little round bodies in degenerating nerve cells in the brainstem of people with Parkinson's disease. And so in this view here of the brain, we're looking at a side of the brain. Here is the brainstem here. And it's in this region where the Lewy bodies tend to accumulate in the cells that produce the nerve chemical dopamine. And it's a lack of dopamine that is responsible for the movement problems in people with Parkinson's disease. Now, when those Lewy bodies, move up to the cortex of the brain, the parts of the brain that are involved with higher level thinking, like language, memory, visual spatial ability, when you see the Lewy bodies in these regions, then they begin to have trouble with cognition. And so both of these conditions can have these Lewy bodies in the brainstem and in the cortex. They also have loss of the nerve cells here in the brainstem that produce dopamine. And this is really important, they both may have changes in the brain, neuropathological changes that are associated with Alzheimer's disease, including neuritic plaques and neurofibrillary tangles. Go back to that slide I showed you that showed over half of individuals in a series of brains from people with dementia had mixed dementia. And so not only do they have the plaques and tangles, but they have a deficit in acetylcholine. And acetylcholine is one of the brain chemicals that's involved in memory. And it's one of the brain chemicals that we use to develop interventions or treatments for the memory problem in people with Alzheimer's disease and Parkinsonian dementias. So the bottom line here is that really the pathology of these two conditions, when you just look at the brain and don't have any access to clinical information, may not be distinguishable. They have very similar pathological features. So here, I just wanted to show you some examples of Lewy bodies. In the brainstem here, you see these target-shaped lesions that are inside the nerve cell. This is melanin pigment. And this is a cell that produces dopamine in the substantia nigra, or the brain stem. And these Lewy bodies contain a protein called alpha-synuclein. And unfortunately, we really don't know the function of alpha-synuclein. We only know that this accumulates in the brains of people with Parkinson's disease. And there's some evidence that this alpha-synuclein can be toxic and contribute to the injury of the cell. Now, when these Lewy bodies migrate up to the cortex, they're a little bit different in their shape. They become irregular in shape. They become less discrete. They're still inside the nerve cell. We have to use a different stain to identify them in the cortex, but they can occur in temporal lobe, in all of the lobes of the brain: frontal lobe, parietal lobe, and occipital lobe. And again, when they reach that stage in the cortex, it tends to be associated with the cognitive features. So here is just a slice of brain through the brain stem, right about here. And this is the part of the brain where those nerve cells are that produce dopamine. And you see this normal pigment. And here is from the brain of an individual with Parkinson's disease, where that pigment is missing because the nerve cells that produce dopamine and have the pigment are degenerated. So what about the treatment for both of these conditions? Because it's very similar. There's really no cure and no treatment to slow progression. We have fairly good symptomatic management of dementia, and it includes medications, OT and PT, exercise, and of course, management of the behavioral complications. So medications to treat both of these disorders really start with cholinesterase inhibitors. You remember I said that both of these conditions tend to have deficits in the chemical acetylcholine, which is one of the chemicals in the brain that helps with memory. So we can give them these medications that prevent the breakdown of acetylcholine in the brain and help to boost memory. And two of these that you're familiar with probably are rivastigmine and donepezil. And both of these have been shown in clinical trials of Parkinson's disease dementia and dementia with Lewy bodies to improve cognition modestly. These are not miracle medications, unfortunately, only modest improvements. But the other thing is they can help with the anxiety and the hallucinations at times. Memantine, another medication used to treat Alzheimer's disease, is associated with marginal improvement in cognition and behavioral symptoms in people with dementia with Lewy bodies and Parkinson's disease dementia, but no improvement in activities of daily living. I tend to really lean on our physical, occupational, and speech and language therapists because they do a great job safety-wise and maintenance-wise to keep patients moving and to keep them safely eating and breathing. So PT and OT in particular can help with motor symptoms. They can teach exercises that the caregiver can do to maintain range of motion and balance. They can give tips on home modifications to prevent falls. They can prescribe devices like canes and walkers that can help with balance problems and prevent falling. Of course, shower chairs are commonly used, handrails in the shower and on the commode. The speech therapist can do a lot to assist with maintaining good communication. Both of these conditions are associated with very quiet and slurred speech, and the speech therapist has very good exercises to try to maintain maintain good speech. And they can also assist with swallowing and preventing aspiration. So how do we manage the hallucinations in these individuals with Parkinson's disease dementia and dementia with Lewy bodies? So the first step is to review all of their medications very carefully, because there is a very long list of medications and it can actually cause hallucinations. And in fact, tops on that list are medications that we use to treat the movement disorder in Parkinson's disease. So this includes medication, any medications that have an effect on the dopamine system, levodopa, amantadine, pramipexole. And so one of the first things that we try to do is decrease the dose of these medications, or eliminate the medication that seems to be the one that might be contributing the most to the hallucinations. There are a variety of antidepressant medications that can contribute to hallucinations. Diphenhydramine, a very commonly used medication for sleep, is associated with hallucinations. And this is just a very short list. But the person should sit down with their provider and go through their medication list and try to decrease the dose or eliminate medications that can contribute to hallucinations. Maximize visual acuity. A good visit to the ophthalmologist or optometrist for corrective lenses or cataract surgery. Maintain good lighting in the hallways. And then, of course, reassurance, comfort, distraction, and safety. Remove guns. Be cautious about having the phone around, because I've had many patients that see things and call 911. So it's a good idea to think of things to maintain safety in the home. So when do we use medications to treat hallucinations in these individuals? The first step is to work very closely with the healthcare provider. And it's hoped that this provider would have some expertise in managing hallucinations in people. It doesn't have to be a psychiatrist. It doesn't have to be a neurologist or a geriatrician, but it should be something that has some familiarity with these medications. And then the next step is to determine if medical therapy is even needed. Are the hallucinations bothering the person? Is the person acting on those hallucinations? Obviously, if they're calling 911 or they're going to their gun cabinet, they need to have some assistance with trying to manage these hallucinations, and medications often can be helpful. Does the patient have delusions or firmly held ideas that are almost certainly not true associated with the hallucinations that make them anxious or frightened or paranoid? So these are the questions that I ask before we make a decision. And I say we're all in this together, make a decision about use of medical therapy. So once we've made the decision to try medical therapy, we set goals, because it might be unreasonable to expect that there'll be no hallucinations. Just let's reduce them to the point that the person is not bothered by them. And then set limits on duration of therapy, because the patient is continuously changing. And so maybe do it for 3 months, decrease it, and see how well they do. And then start low with these medications and go slow, and use the newer atypical antipsychotic medications. And the three that to me are the most commonly used are clozapine, that really requires close monitoring, usually by a psychiatrist, quetiapine, and pimavanserin. So finally, exercise in the treatment. And before I really talk about exercise, I just want to say, individuals with dementia, remember, apathy is a very common symptom. So, if they at first aren't into this exercise. Don't force the issue. Maybe they would want to go out with you as a family member or a care provider, or maybe they might want to go to a group with some friends and start something. It's a very difficult, and I just don't like to force the issue of exercise, but it can be helpful. And we know that it improves the motor function and balance for people with Parkinson's disease. And the best really is aerobic exercise, walking, swimming. And this is actually better than weight training and formal resistance training. There are studies that show that Tai Chi and dance improve balance in these individuals, but you should choose the exercise that the person is capable of performing and hopefully enjoys. So there are barriers. There are low expectations for a positive benefit, but there's been lots of studies that show improved quality of life. There's concern about how much time, and just 20, 30 minutes a day is beneficial. And then, of course, the fall risk associated with exercise. And there are things that a person can do with their partner that would not be associated with a significant fall risk. So I'm going to spend a little bit of time on these atypical dementias that I referred to a little while ago. They're all associated with the same core features, but they have atypical features that make them a little bit unusual in their clinical course, and they have distinct neuropathological features and different ways of treating, but they're often misdiagnosed as Parkinson's disease. So, and they often have behavioral features, including disinhibition and anxiety and depression. The dementia syndrome is very similar to Parkinson's disease and dementia with Lewy bodies: mental slowness, apathy, withdrawal, prominent executive function deficits. So the first one is multiple system atrophy. This is very uncommon. Onset is younger than that of Parkinson's disease, and these individuals tend to have falls early in the course. The core feature, the atypical part of this, is very prominent impairment in the autonomic nervous system. The autonomic nervous system is the part of the nervous system that controls involuntary functions: breathing, heart rate, digestion. And so an impairment in this part of the nervous system can cause abnormalities in each one of those functions. So dizziness is very common. Fainting is very common. Problems with urination and incontinence tends to occur very early in the course. Impotence in men, abnormal perspiration and sweating, and even Raynaud's phenomena, or cold and dusky hands. About 2/3 of these individuals actually have REM sleep behavior disorder, and this is related to the pathology that is also associated with Lewy bodies, but in different parts of the brain. And they can have other sleep problems as well, such as sleep apnea and inspiratory laryngeal stridor, or croupy breathing. The treatment really relies on physical, occupational, and speech therapy. We don't have a good way of managing the cognitive features of this condition, and the medications that we use for Parkinson's disease, for the movement disorder, really aren't very helpful in the long run. We do have good medications for the dizziness. You can start by increasing salt intake, putting stockings on to increase the return of blood, elevate the head of the bed at night, frequent small meals, and caution after meals or exercise. And then there are medications such as fludrocortisone, midodrine, and droxidopa that do help with the dizziness. Progressive supranuclear palsy is, again, very underdiagnosed. The mean onset is about 65 years, a little lower than Parkinson's disease and DLB, and survival is a little less at 6 to 10 years. Again, falling may be the presenting feature. They have slow movement, they have double vision and blurred vision, and they have a lot of difficulty with speech and swallowing. And the characteristic feature of this that causes its name, progressive supranuclear palsy, are involvement of the eye movements. The eye movements are very slow, and they have very limited ability to look up and down at first, and then finally limited ability to look sideways. And they also have forced eyelid closure or blepharospasm that really interferes with their vision. And of course, they have difficulty swallowing and trouble sleeping at night. They don't respond very well to dopamine medications. Some respond a little bit to amantadine. Botulinum toxin is helpful for the blepharospasm. And again, physical, occupational, and speech therapy. Cortical basal degeneration is also uncommon. Men and women are equally effective. Survival, again, is a little bit less at about 8 years. The Parkinsonian syndrome is the same. The atypical features are cortical sensory loss, that is the inability to correctly interpret sensory information. The presence of a tremor that is not a rest tremor, but an action tremor, or a tremor that worsens with doing something with the hand. And then very prominent speech slurring and apraxia, or effortful speech and halting speech. They may have slow eye movements. And then a very peculiar characteristic is the alien limb phenomenon. And some of these individuals, one of their limbs, one of their arms, tends to appear like it acts independently of the individual. So they may walk down an aisle and the hand reach out and touch or grab somebody sitting in a chair involuntarily. They seem not to have control of that hand. We call that alien limb phenomenon. Levodopa or the dopaminergic medications really don't help. Again, we depend on physical therapy, occupational therapy, and speech therapy. Sometimes clonazepam helps with the tremor. And then finally, I'm just going to say a couple words about vascular Parkinsonism. And of course, these are small strokes that cause Parkinsonism and dementia. So anytime you have a stroke, you expect to have vascular risk factors like high blood pressure, diabetes, smoking, and high cholesterol. The characteristic Parkinsonism is something that we call lower body Parkinsonism. They have a rigidity in their legs, but not so much in their arms. They have a shuffling gait with hesitation when trying to start their walking, but they are able to use their hands without a lot of difficulty. And then they have early postural instability with a lot of falls. They very rarely have tremor. So the neuropathological features of all these atypical syndromes are varied. Multiple system atrophy is another condition associated with Lewy bodies and deposits of this protein called alpha-synuclein. And if you look at these three conditions, Parkinson's disease, dementia, dementia with Lewy bodies, multiple system atrophy, they're all connected by alpha-synuclein, and they all have REM sleep behavior disorder. Tau is another abnormal protein that becomes aggregated in cells in the form of neurofibrillary tangles. And you've heard of these tangles in Alzheimer's disease. They also occur in progressive supranuclear palsy and cortical basal degeneration. And then finally, of course, in cerebrovascular disease, in vascular Parkinsonism, you have cerebrovascular lesions or small strokes. And usually these strokes are located deep in the middle of the brain. So I just want to, this slide really is not so much for the care providers out there, because you folks know this better than anyone. This is really for us as healthcare providers. I just wanted to talk a little bit about the features of these dementia syndromes with Parkinsonism that are most likely to contribute to care provider distress. There have been several studies of these characteristics, and the ones that really come out are one, psychosis, and that is the presence of hallucinations, delusions, and agitation. Excuse me. Two are the affective disturbances, anxiety, depression, and apathy or loss of interest. And three is the impaired ability to perform activities of daily living, such as managing finances, shopping, transportation, housekeeping, feeding, grooming, dressing, bathing, and toileting. So these are the things that really increase the distress on care providers. So these are the things that as healthcare providers, we should be trying to do the most for when we're treating our patients with these conditions. One thing that the final thing that I want to say is that there have actually been studies that have measured caregiver burden comparing Alzheimer's disease to these Parkinsonian dementias. And the caregiver burden for Parkinsonian dementias is just as severe, and in some cases even more severe than that for Alzheimer's disease. So that really concludes my talk. I want to thank you for your attention. I'd like to thank Catholic Charities of Hawaii for inviting me to speak on this topic. And I want to thank the Department of Veterans Affairs, Pacific Health Research and Education Institute, Kuakini Medical Center, and the University of Hawaii John A. Burns School of Medicine for their support as well.